Good afternoon, everyone. My name is James O'Leary, and I'm the Chief Innovation Officer at Genetic Alliance. I'd like to thank you for attending today's webinar, Implementing Public Health Genomics in Your State, Resources from the CDC Office of Public Health Genomics. This webinar is presented in collaboration with Genetic Alliance and the American Public Health Association Genomics Forum. As a reminder, today's webinar will be recorded, and webinar archives are available on the geneticalliance.org website. We should have that up later this week, so if you want to refer anyone to this webinar or go back and look at details, that information will be available. In addition, I do want to remind you that attendees for this presentation are muted. And what that means is that you can still ask questions, but you should use the chat box on the panel on the right-hand side of your screen. Feel free to ask questions throughout the webinar, though we will not be addressing those questions until the Q&A at the end of the session. In fact, I encourage you to submit them early, and that way we can kind of lump together similar questions for our presenters today. With that, I do want to introduce our moderator for today's session, Muin Khoury from the Office of Public Health Genomics. Muin, thank you so much for joining us.
Sure. Thank you, James, and good afternoon, everyone, or good evening, or good morning, depending on where you are in the world. We're going to take a little bit of your time today to tell you about some of the resources we have at the CDC Office of Public Health Genomics for implementing public health genomics in your state. The focus will be on state implementation programs, but as you will see that there will be a little bit of other things for people interested in the healthcare public health interface and some researchers. We have 3 speakers today, Martha Gwynn, Dave Dodson, and Ridgely Fisk-Green. So I want to start with this image of the organizing the information that we have in our office according to the phases of translation. Obviously, there's a lot of excitement and genomic discoveries at the bench and the bedside, and however, much less has reached a point of maturation to reach guidelines and recommendations, and even less reaching practice and programs, and even less measuring outcomes at the population level. So we focus mostly on the more distal part of the translation, the initial phases of research and development, drug devices and tests, and then evaluation of these tests through observational studies, clinical trials, epidemiological studies, and reviews. And this is where sort of our action starts in terms of implementation of guidelines into practice, what we call health services research or implementation science, and then measuring impact at the population level through surveillance, outcome research, and comparative effectiveness. Just as a background for the group here, there is a lot of action early on in the phases of discovery and translation, but about 1% of all the activities, the studies, and the funding goes into that beyond bench to bedside. We call it the road less traveled, and we are determined to make that road even more traveled in the next few years. So without further ado, I want to introduce our speakers today, and this is a screenshot from our website. I encourage you to go visit it, but our focus will be on 3 activities today. We're going to start with a description of our public health genomics knowledge base that Martha Gwynn will give us. And then after that, we will focus on genomic testing and our evidence-based tiered classification of tests. And Dave Dodson will talk about that. And last but not least, we're going to hear from Ridgely about our implementation tools and resources and activities. And as James said, we would love to hear from you throughout. Type in your comments and feedback, questions, and we are even happy to continue the conversation long after the webinar. So without further ado, I'm going to turn it to Martha Gwynn to talk about the public health genomics knowledge base. Martha?
Thanks, Muin, and hi, everyone. I'm just going to offer a bit of an orientation and overview to what we call the public health genomics knowledge base. This is a box on the home page of our website. And it takes you to a page that looks like this, the About page for Public Health Genomics Knowledge Base, or PHGKB. Now, the contents of the knowledge base are actually organized behind the scenes into multiple components, and those are shown here in this list of all databases. So I'm going to describe these in a little bit more detail. You'll see that that the components of each of these are acquired in slightly different ways and for somewhat different purposes. I'll explain just a little bit about what those are, where we find the content for each database, and then we'll be discussing throughout the program today how you can use the Public Health Genomics Knowledge Base. So first, what are the different databases? You'll see at the top, two are related specifically to CDC-produced information. So that includes both web pages and also CDC-authored publications or journal articles that have something to do with human genomics or family history. We're not going to discuss those in a lot of detail since they are already accessible to you. We also have something called the Huge Navigator that's been in existence since 2001 and is a database of genetic association studies that are collected from PubMed. I'm not going to discuss those, that particular database in any further detail. Now, in my section here, I will give you a little bit of an overview of the Genomics and Health Impact Scan database and also the Advanced Molecular Detection clips. Subsequently, you'll hear in a lot more detail about two components of PHTKB that have to do with genomic tests, the guidelines database and the tier table, which Dave Dawson will discuss. And finally, what's probably most relevant to state and local public health is the implementation database, which Richley Fitzgreen will discuss. So if you are a recipient of our weekly update, or if you visit the home page and click on what's new, you will see the current edition of the Genomics and Health Impact Update. This is published weekly on the website, and notification is sent to people who have subscribed to the update via GovDelivery. So this is the most recent edition, and you'll see at the top there's the spotlight. And the contents of the weekly update are compiled each week into an archive that comprises the Genomics and Health Impact Scan database. So each week, we find new things, we post them on the website, and then they're added to the database. Why did we do this? Because it's difficult to keep up with news in genomics and family health history developments that are relevant to public health. We saw an opportunity to identify the latest publications and other resources on population-based applications. We also face the challenge that many people hold the misconception that genomics applies only to research or perhaps clinical practice. But what we want to do is to highlight public health applications of genomics and the role of public health at the healthcare interface. So where do we find the information? It's via Horizon Scan. And what I mean by that is that we have a systematic approach to monitoring a series of Google alerts, PubMed queries, key websites, such as the Genetic Alliance, and other sources. We select news stories, blog posts, scientific articles, reports, and links to websites that are relevant to our focus. As I said, these are published online in the weekly update and added to the searchable database. In the database, these items are indexed by category as well as translation phase. So you'll see across the top the T0 and 1, T2, and T3 of 4 phases of translation that Wayne just mentioned. Down the left side, you see that we've also further classified these items into categories to distinguish original studies from research synthesis, modeling, and meta-analysis, guidelines and policies, and finally, tools and educational materials. I'll just mention briefly the Advanced Molecular Detection clips. This is another weekly update that we produce that's focused on pathogen genetics. So not just the human genome, but the use of next-generation sequencing in infectious disease public health surveillance investigation and development of new diagnostics. This is also available from the PHGKV homepage, and the contents are also compiled weekly into a searchable database. Now, it's possible to search the entire public health genomics knowledge base with a single search here in this box here on the main page. It's identical actually to the search key down here. To do this, you type something into the box, such as breast cancer, hit search, and you'll have an array of information organized, first of all, under what's new, things that have been added to the database since the last update. So here, if you take a look at these are all actually journal articles that have been added through the Horizon scan and will be appearing in the next update. Scrolling down the page, you see the output of the overall search organized into categories that are defined by these blocks. And just to explain briefly where the contents come from, the CDC information, as you might imagine, feeds into CDC resources. The Genomics and Health Impact Scan contributes to the translational research category, and Huge Navigator primarily contributes to epidemiology. The Impact Scan database is also the source for most of the items in our evidence synthesis category. And then the guideline and tier table databases feed directly into this block labeled evidence synthesis, and this is what Dave is going to discuss next. Finally, the implementation database corresponds to the block on the lower right. Okay, I'm ready to hand the baton to you, Dave, for genomic testing.
Okay, thank you, Marta. And I'm Dave Dodson, as has been mentioned, and I'm going to tell you a little bit about what we do regarding genomic testing and how it fits into the PHGKV. And the first thing I'm going to tell you about is our guidelines database. And one of the things over the years that I've noticed is that it can be really difficult to find guidelines and recommendations that include information on genomics and family health history. This is especially true if there may be guidelines that are very broad and just a little aspect may cover something to do with, say, family history. So it can make it really difficult for searching. So we wanted to compile a centralized, searchable, publicly available database for guidelines and recommendations, as well as policies that are related to genomics and family history. And also for relevant guidelines, policies, and recommendations are developed independently by a bunch of different groups, and they update them on different schedules. So we wanted to make a repository where it would be easy to find the most recent guidelines. Thank you. Okay, and here's an example. If you're using the guidelines database, there's a search box, and if you typed in lung cancer, I just wanted to show you get several guidelines from different groups. In this case, you can see you've got guidelines from the U.S. Preventive Services Task Force and ASCO and other groups. And from there, you can go and link to the PubMed record for each of these if you want to get the full text. And the other aspect I wanted to talk to you about is the tier table database, and what this is a repository of genomic applications classified according to the level of evidence supporting their use. We created it as a demonstration of a method for organizing our Horizon scanning results, and we wanted it to be useful to help in informed decision making It's based, when I say genomic applications instead of genomic tests, it's based on how these tests are used, what population they're used in, and what purpose the test is used for. That's why we say that it's based on different scenarios rather than on a specific test. It's more about the use of it. We use a systematic process to go through and rank the tests according to a three-tier system. But it's also a subjective and context-dependent process. And what I mean by that is that the ranking system reflects the things that we felt are important in determining what's ready to implement. So other people may have different criteria that they want to use. And it's, in our case, it's a US-centric tool. So the context that we operate in is the U.S. healthcare system, so the weighting might reflect, in some respects, that. And here's how the ranking of the different genomic applications works in our system. You can see here that there's 3 tiers, Tier 1, 2, and 3, that we've color-coded as Tier 1 is green, Tier 2 yellow, Tier 3 red, and the overall, I guess, message that, or the way we see it is items that can be categorized as Tier 1 green are generally ready to go in terms of implementation. Tier 2 yellow, there's less clear evidence, and so you may be able to use these in informed decision-making scenarios. There's some useful information out there. It's just that it's not so clear whether testing is recommended or not. And Tier 3 red, either there's no synthesized evidence, no guidelines, systematic reviews, or different groups have recommended against use of a test in a particular scenario. So, and just examples of criteria that we use for Tier 1 green, if there's a pharmacogenomic application and FDA, the drug label for a particular drug, says you have to do the testing in order to, or they require testing as part of the label, then we would call it Tier 1 automatically based on that. Or if the Center for Medicare and Medicaid Services covers testing, we count that as Tier 1. And also anything where there's a clinical practice guideline that's based on a systematic review and they say, yeah, they support testing, then we'd call that Tier 1. The Tier 2 yellow, there's just, as I said, the evidence is not quite as clear, so you might get guidelines where they find insufficient evidence, or FDA maybe just mentions a gene or a biomarker, but they don't say you have to test in order to prescribe this drug. Or CMS might cover or issue a coverage with evidence development statement. So, and finally, for Tier 3, examples might be if CMS looks at a test and they decide they're not going to cover it because there's just not enough evidence, or you have a guideline from an independent group that recommends against using the test. Or as I mentioned, sometimes we just go through our different sources and search and don't find any guidelines, systematic reviews, or any synthesized information, only primary studies. And in our system, it's Tier 3. And some caveats about what the tier table isn't. It's not, we wanted people to be able to use it to help in informed decision making, but it's not a substitute for that process. And it's really not an endorsement or recommendation for or against anything by our office or anyone else. It's not comprehensive or a complete assessment of tests or scenarios, and it's certainly not the final word in determining what's ready to implement. And the biggest thing, I think, for these last 2 bullets is it's really no substitute for actually going and reading the evidence sources that we use to classify these things. We kind of make decisions based on our reading of it, but it doesn't, we don't mean to say that you can just look at our ranking and avoid reading what's in the guidelines and reviews and things like that. So the reasons why we built it, there's so much information on genomic tests out there right now. and conflicting information. In many of the tests, the utility is not really proven. So we hope that we could help to educate providers and the public about potential benefits and harms of these tests, and also the need for evidence on the test and on clinical utility. Also, there's no threshold level of evidence that's widely accepted to determine whether tests are ready for use or not. And so we wanted to show that we could get people together. And when we developed this system, it was our office here at OPIG CDC. We also had several people from the National Cancer Institute and colleagues from other places that got together and spent a long time trying to come to agreement on this. And what we wanted to do was just make a flexible system that as a demonstration of how you can go about coming up with thresholds for different purposes. So we create thresholds for what's tier 1, tier 2, tier 3, and in the paper that we put out describing this process, it's other groups are going to find that these criteria don't quite work for them, but it's flexible enough so that you can change these things and come up with your individualized processes for determining threshold and ranking tests according to that. So if you go to the tier table database, up on the upper left-hand side, what you're going to see is just basically an empty search box where it says enter a search term. And in this example, what I've done is just hit the search button without entering anything. And it comes back, all the results are returned. And then underneath that, it lets you filter. So I filter by tier level. And then at the bottom right, you can see that the numbers of tests in each of the categories that we've currently got in the database. So if you click in the box beside tier 1 and hit continue at the bottom, you'd come up with a list like this that shows lots of different tests that we have categorized as tier 1. And in this case, I'm going to show you from here. You can choose the detail tab, and I'm using one from BRCA-related cancer, hereditary breast and ovarian cancer. Family history is the test to be assessed. So, and the intended use here is risk prediction for referral for BRCA genetic counseling. And the next column, you can see it's ranked as tier 1. And if you hit the detail button that I've got circled on the right, it'll take you to a page with more information. And here you can see, again, that the test to be assessed, family history, the target population in this case is women, intended use is risk prediction, referral for BRCA genetic counseling, and the basis, the primary basis for the classification is tier 1 in this case is a guideline from the United States Preventive Services Task Force. This one's from 2013 or 2014 recommending this. And here's another detail page for another tier 1 application. This is Lynch syndrome testing. And this is really the test to be assessed. This particular case, they're looking at various strategies. And the target population is patients with newly diagnosed colorectal cancer. And this is about cascade screening, so testing of relatives to benefit relatives based on an EGAP recommendation from 2009 that recommended testing all patients with newly diagnosed colorectal cancer for benefits of their family members. And finally, another tier 1 application I wanted to show you is familial hypercholesterolemia. And here we're looking at the test as DNA testing and LDL-C concentration measurement. And this is based on a NICE guideline, and which is it's in the UK. So I had mentioned we are the way we use our tier table. It is kind of U.S. centric, but we do look at evidence and guidance from overseas groups as well, especially when they use evidence-based processes such as NICE does. And I wanted to show you one example of a Tier 3 genomic application. This is also related to hereditary breast ovarian cancer, and it's based on the same guideline that we put one of these into a Tier 1 U.S. Preventive Services Task Force, but in this case, it's the intended use is population screening, where the task force recommended against it. So in this case, this would be a Tier 3 genomic application. So from there, I'll go ahead and turn you over to Ridgely Fisk-Green, who's going to tell you more about implementation.
Thank you, Dave. So I'm going to start off by first talking about a few new resources that we have that are geared more towards the general public. We encourage states to link to these resources and to use the content in building their own pages on these topics. So the first one is our Genomics and Diseases page, which has links to information on these different diseases as they relate to genomics and family history. And I'd just like to highlight the page on hereditary breast and ovarian cancer because we have a whole new series of pages on this disease as it relates to genetics and family history. So we encourage you to visit that. It's grouped by life stage and also has information for providers as well. And then also we have recently redone our family health history pages. And we encourage you to visit those also. And this talks about family health history as it refers to different life stages and has information for different audiences. So again, invite you to visit those pages, encourage you to link to them, and please feel free to use the content in building your own pages on these topics. So now I'm going to go into the implementation resources that we have. And I want to encourage states to please let us know about resources that you have in your state because we're trying to keep track of what's available, and we'd love to know about what you have going on in your state. So I'm going to start off by talking about the public health. I'm sorry, you reach this by going to that implementation tab, and you'll come to this page. And I'm going to start off by talking about the Public Health Genomic Tier 1 Toolkit. Then I'm going to talk about the implementation database, which is part of PHGKV, which Marta talked about. And then lastly, I'm going to talk about the state implementation clickable map. So if you go to the toolkit, it will look like this. And just a heads up that we are in the process of updating it. So it may look a little bit different if you visit it at some point in the future. So this is what it looks like now. And the goal of the Tier Kit is to assist state and local public health departments in implementing Tier 1 recommendations using strategies from model state programs. So these are strategies that other states have already used. And it focuses on the 3 Tier 1 conditions that Dave talked about: hereditary breast and ovarian cancer, Lynch syndrome or HNPCC, and familial hypercholesterolemia. So the approaches included in the toolkit include implementing bidirectional cancer registry reporting, that is, using cancer registry information to identify individuals who are increased risk for hereditary breast and ovarian cancer or Lynch syndrome, informing policymaking, developing surveillance indicators, tracking progress towards Healthy People 2020 genomic objectives, providing education and outreach, and promoting cascade test screening. So we do have some new materials. If you've looked at the toolkit before, you might not have seen these, which were developed in collaboration with Genetic Alliance, and which were based on materials used by Michigan and Connecticut in their bidirectional cancer registry reporting program. These materials are customizable written materials. They're downloadable, and states are free to add their own branding. And they're really designed to serve as a starting point for states to use if they want a bidirectional cancer registry reporting program. Feel free to change the content, make it look different, change it however it is useful for you. It includes information for providers, information for patients and families, and reporting tools. And I refer to it as bidirectional cancer registry reporting written materials, but really these materials are useful for a wide range of activities. They're useful for cascade screening and other applications. So states, even if you're not interested in bidirectional cancer registry reporting, these written materials can be used for a whole variety of different purposes. So we really encourage you to take a look, even if that's not something that you're interested in.
So to access these materials, we have them for both Lynch syndrome and hereditary breast and ovarian cancer. We don't currently have them for familial hypercholesterolemia. So just showing how you get there for Lynch syndrome, you would click on Lynch syndrome and open up the larger tab and then go to the tools page, and it will look like this. And you'll see information for patients and their families, information for providers, and reporting tools. So in terms of the information for patients and their families, and these are all, I should add, downloadable as Microsoft Word or PowerPoint documents, so they should be very easy for you all to change and to use and make your own. So for patients and their families, we have fact sheets on both Lynch syndrome and hereditary breast and ovarian cancer syndrome, which are written at the level that they should be understandable by patients and their families. We have a template that states can use to compile these cancer genetic specialists in their state or region. We have a frequently asked questions document on how cancer registries work, which is useful for patients and their families, as well as some providers that are not so familiar with how these registries work. And then we also have letters for individuals who have had genetic testing and found that they have either a BRCA mutation or a Lynch syndrome associated mutation. And these letters are intended for these individuals to use to give to their family to let them know about their mutation. And we encourage individuals to talk to families and not just send them the letter. And so to facilitate that, there's a brochure on how to talk to their family. So, and this brochure is actually in a PowerPoint format. Everything else is in a Microsoft Word document format. And this is one side of the brochure. And it has personal stories about what it's like to have that have a mutation associated with Lynch syndrome or a BRCA mutation. And it also just has tips that individuals can use in talking to their family about this. And again, these are things that states can customize and change fairly easily. In terms of resources for providers, we have fact sheets on both Lynch syndrome and hereditary breast and ovarian cancer syndrome, and you'll see there's space for states to add their own branding. We also have summaries of the evidence-based practice guidelines, which we will be updating to keep current with the guidelines as they change, as well as a video that actually explains what bidirectional reporting is. So for states that are thinking of implementing this, this video goes through the basics of it so that if providers are going to be part of this program, they know what it's about. And that's featuring Dr. Greg Zero. It also includes reporting tools, and these were based on the tools that Connecticut and Michigan used when they had their bidirectional reporting programs. So here are two sample data reporting forms for Lynch syndrome and for hereditary breast and ovarian cancer that states can use. In addition, and this is not available yet, but hopefully will be available soon, we have a PowerPoint slide set for outreach to providers and institutions. So in some states, as part of their bidirectional reporting program, or just as part of their outreach to the institutions in their state to let them know about these hereditary cancers, they've had genetic counselors or others go out and present at grand rounds or other times at the different institutions in their states. And so the idea of this PowerPoint slide set is, rather than having to start from scratch with the slide set, you have a slide set that you can pick and choose slides from. It's a pretty big slide set, so we're not anticipating that someone would use the entire set in one talk, but you could if you wanted to. But really, so rather than having, again, to start from scratch, you have a series of slides that you can use for that. So we hope that will make things a little bit easier for states. And we really encourage you to contact us and let us know about other resources that we might be able to provide similar to this that would be helpful for your program. So in addition to these resources, which, like I said, we refer to them as bidirectional cancer registry reporting resources, but really they're useful for a variety of uses. There's also examples of strategies that states have used in implementing genomics activities in their states using other tactics. These include informing evidence-based policymaking approaches. So these include educating payers about the USPSTF, NCCN, and EGAP recommendations. And again, that PowerPoint slide set has slides that could be useful for this. Assessing which health plans have policies consistent with these recommendations, and acknowledging health plans with policies that are consistent with current recommendations. Other approaches include meeting with health insurance plan medical directors, conducting key informant interviews with health plan administrators to address barriers and facilitators to having evidence-based coverage policies, and developing and disseminating policy guidance documents for insurers. Incorporating genomics activities into the state cancer control plan, the state cardiovascular disease prevention plan, and the stroke prevention plan, creating a list of alternative payment modalities for underinsured women, and participating in the Lynch syndrome screening network. And for those of you who don't know more about that, Deb Duquette, who I think may be on the call, is a great resource to find out more about LSSN. In terms of data sources that states have used, these include the Behavioral Risk Factor Surveillance System, claims data, cancer registry data, genetic services data from the genetics clinics in the state, surveys of healthcare providers, and state-specific data systems. Examples of outreach include board-certified genetic counselors providing in-service training to providers. Again, that slide set might be useful for this if your state would like to do that. A clinical decision support tool containing referral criteria for hereditary breast and ovarian cancer syndrome. For those of you who are familiar with Michigan's Wheel, that's one example, and Connecticut has some pens that can help with that. CME materials, for those of you who are familiar, this includes the Is Your Patient at Risk tool, which addresses hereditary breast and ovarian cancer syndrome, and there's also one on Lynch syndrome. And then partnerships between states to create and disseminate materials. It also includes surveying providers to identify knowledge gaps, developing community-specific outreach to target at-risk populations. So, for example, developing materials in languages other than English. And one possibility of materials we could supply if states are interested in is some of those written materials being translated into Spanish is, for example, something that we could look into if that's of use. Awareness days and communicating via in-person conferences, displays at health fairs, online modules and webinars, provider newsletters, and information at clinicians' offices. And lastly, there's a little bit on, and hopefully will be more in the future, on cascade screening. So what cascade screening is it's the active process of finding relatives of index patients. So once someone's identified as having a BRCA mutation or having a Lynch syndrome-associated mutation or having familial hypercholesterolemia, finding relatives of that person at a pre-symptomatic stage. And the goal of that is informing those relatives about available testing and intervention so that they have the chance of taking advantage of those before they get sick. So moving on, so that's the toolkit. So now I'm going to move on to talk about the implementation database. And this is part of PHGKV, which you heard about from Marta and Dave. So why did we build this implementation database? Well, the challenge is that state, local, and territorial health departments need practical information that they can use to integrate genomics and family history into their activities. So the goal of this database is to provide a searchable database of available resources categorized by research type, disease, and state so that health departments can find new resources and learn from other states. Another challenge that we were hoping to meet is that state, local, and territorial public health departments and policymakers want to know about genomic and family health history activities in their state and community. And these activities can be searched by state and can also be identified through the clickable map, which we'll talk about after this. So this is what the implementation database page looks like. And if you do a search on it, you can use the filters as you see with the arrow right here to fine-tune your search. And the items in the implementation database are curated and categorized by the disease, excuse me, sorry, by the state in which the activities are occurring, by the resource type, so data, policy, education, tools, programs, general information. And these are just categories that we came up with, but we'd love to have feedback on whether these are useful to you all. If you think categorizing these in a different way would be more helpful, please do let us know. And they're also categorized by the disease or topic that this resource fits with. So, and everything in the implementation database includes activities from all states. If you want to search specifically with your state, it's in ways easier to use the clickable map, which is shown here and The arrow shows you where you go to access it. Excuse me, sorry. The resources that are included in the implementation database completely overlap with those in the state clickable map. So everything in the implementation database, you can also find through the clickable map and vice versa. And this is a work in progress, so if you click on your state and there are some activities that aren't there and you want us to know about them, please do tell us. So the link to PhDKB is on the top. Our email is on the bottom, so please, we'd love to hear about what's going on in your state. Please do let us know. And we hope that you have a chance to look at all the different resources that we've talked about. And we will be sending out an evaluation form in a little bit. And we hope that you will take the time to fill it out and give us that feedback. Even if you haven't had a chance to look at the resources, we'd still like to hear from you. So please do, if you can, take a chance to look at those resources or look at that survey and fill it out when we send it to you. And I'd like to thank Genetic Alliance and all of the attendees. We really appreciate you taking the time to spend with us.
Right. So thank you, Ridgely. Thank you, Martha. Thank you, Dave. This is back to Moeen. James, it's up to you now. We have a little bit of time for Q&A. If you have some questions for us, we can turf them to the people who can answer them. So what do you have for us?
Great, great. Okay, just a reminder, everyone, please submit your questions using the panel on the right-hand side of the screen. I'm going to get started with some that were submitted during the session. The first one is, could you share any success stories on how to incorporate rare diseases of congenital origin in the comprehensive public health approach? Any valuable suggestions for the inclusion of, for example, Leber's congenital amaurosis into the global initiative for the elimination of avoidable blindness, Vision 2020. And then in parentheses, the right to cite is the Global Initiative for Elimination of Avoidable Blindness, a joint program of the World Health Organization and the International Agency for the Prevention of Blindness. And I will send the speakers this question as well.
Right. So this is Moeen here, and we appreciate this question. So the CDC has had multiple programs to deal with rare diseases. Most of the activities reside in the National Center on Birth Defects and Developmental Disabilities, for which there are featured birth defect surveillance systems, activities relevant to a few of the genetic disorders like Duchenne muscular dystrophy, Fragile X syndrome, and a few others. We recently published a sort of a paper and about the need for a public health global approach to the issues of rare diseases. And what's really needed right now is that intersection between public health, genomics, and rare disease, because most of the activities seem to show that, and some of the research is that by doing more and more genomic analysis, you're going to be diagnosing more and more of the rare diseases. As a matter of fact, more than half, or depending on where you read, there is a lot of hidden genetic conditions that can only be uncovered through whole exome and whole genome sequencing in high-risk families or in familial conditions. Beyond that, there is, the focus of our presentation has not been on the rare disease, although we try to track that and in a way that makes sense, and depending on the resources that are available for CDC program to tackle them. I wonder if, Ridgely, you came from that birth defect center, if you have anything to add to this.
I know there's been a lot of work on hearing, and I don't think there's been as much on vision. I don't have much to add. I guess I would just say that if we pick up resources, they will be included in PhDKB. Right. We haven't had any kind of a focus on rare diseases in the state toolkit as of now, but those resources should be included in PhDKB, and we certainly would like to list any resources that states have. So please do let us know. That would be great.
Thank you.
Great, thank you. The next question is, when do you anticipate the PowerPoint for provider outreach being available, and can a copy of the slides presented today be made available?
We're certainly happy to make the slides that were presented today available. I'm hoping that those PowerPoint slides should be available within the next month or two. And if anyone specifically is interested in those, please do please do send an email to our mailbox listed on the list that you can see listed right now, and we'll make sure that we can send you a copy of those slides as soon as they're available, provided that they're not so large that we can't email them to you, but we'll let you know when they're available.
I think we can post the PowerPoint, and also we'll work with Genetic Alliance to see, because you will post the whole webinar,
Right.
and if we can post the PowerPoint, everyone can have access to that.
Absolutely. Great, thank you. The next question is, does CDC have guidelines for prenatal care for various ethnic groups?
So on our family history pages, we do have information on use of family history both before pregnancy and during pregnancy, and those pages are different because just at least in terms of considerations, it is a little bit different once you're pregnant versus before. Our focus right now has been on family health history.
Great. There's a question, would you please repeat the link to find the Genomics resource toolkit on your website?
The link to the resource?
So if you go to the main Genomics, it's probably easier just to show you how to get there from the main page rather than giving you a very long link. If you go to our main page, which we're pulling up right now. So if you go to our main page and you click on the third column down on the right where it says implementation.
Okay, let me go do it in real time.
Sorry. Yeah, so we're pulling up our web page so that you can actually see us click through to it. So you'll see right now. So you will see the link actually now. Big long link.
Sorry. Okay. Whoa.
Yeah.
Hold
Too
up.
many W's.
Oh. Oh, that's the right W's. Anyway, let me get this up.
Yeah.
Oh, yeah. There we go. There we go. Okay.
Okay, so if you go to our main page and you scroll down and you click on the third item in the second column, which says implementation, and then scroll down again, and the third item down on that list of clickable links says toolkit, or you can click on it from, if you go to the left nav, there's also a link that you can click on. So either there in the main list or on the left, and then you'll get to the toolkit. And for each disease, it has its own sort of subset of pages. And as I mentioned, we are in the process of updating this, so don't be shocked if you go and it looks a little bit different. But all the links should still work the same.
Yeah, I just want to say something to the people who are attending the webinar. I know there is wide-ranging interest in genomics across the life stages, and the reason why we started with these 3 conditions for adults primarily is because of the existence of evidence-based guidelines and the sheer numbers that these 3 conditions, there's about 2 million people in the U.S. that have them, and most people who have these conditions don't know they have them. And so there are opportunities for immediate prevention for public health and the healthcare interface. Now, that doesn't mean that any of the other 5,000 genetic conditions are not important or anything like that. There's always room for additional activities that are done by various programs at CDC. James, back to you.
Okay, great. So the next question is it the case that state activity displayed by the implementation database is only there if states report that it exists? Is this essentially a comprehensive listing of what's at the state level, or limited by what's submitted?
Can you repeat the last part of what you said, James?
Sure. So can it be relied on as a comprehensive listing of what's at the state level?
No, certainly not, and that's why I'm asking states to please let us know about resources that you have. I mean, everything included in the implementation database is either going to be a journal article or a link to a website. It's not going to be any kind of a text on what's going on in that state. It's all linking to outside links or to publications. But certainly this, like I said, this is a work in progress. So if there's something that's going on in your state, we would love to know about it. We would love to be able to share information about what's going on. So please do tell us. And I'm sure it's not comprehensive because it's sort of, it hasn't been a systematic process. It's sort of been finding out about things and adding them as we go along.
Okay, great, thank you. We do have plenty of time for questions. I have 2 more questions submitted, but if you have a question, please send it to me now and I will add it to the list. The next question is, how should providers looking at Tier 3 tests respond to the fact that tests classified in that category are either recommended against use or there isn't enough evidence? In other words, the fact that there are 2 kinds of Tier 3 tests.
And the question was, how should providers respond? Is that right?
Yes, that's correct.
Well, I mean, I can't really speak for providers, but to me, the way I see it is that, yeah, we've grouped 2 things together that are fundamentally different. Either you don't have any synthesized information, or you do have enough to say for a guideline group to say no, you don't want to use it. But I think that you know, even though they're qualitatively different, in terms of looking at what's our interest is saying what's ready for implementation at the population level, it's just something that where we have bent them there because we're not looking at them imminently as things that should be used on a population level.
I just want to add a little bit to what Dave just said. If you look at the tier table, and it's been a while, we have updated it. The tier 3 has very few items right now. The items that are there are mostly genomic applications have been recommended against. There is a whole lot of genomic applications that are not in tier 3 for which the data is insufficient, and we didn't even bother putting the whole sea or world of genomics in tier 3. They kind of fall out. So in a way, the current tier 3 is more or less designed to display the recommended against or insufficient evidence, things that have been looked at, but there is a lot that hasn't been looked at. And you know, when I looked at the slides as Dave was presented, I said, gee, there's only 8 things in tier 3, and that's because we were looking at it systematically from the point of view of recommendations. So at the end of the day, as Dave said, these tools are guides for providers and the general public, and also policymakers at the population level trying to figure out where the action is in terms of implementation, in terms of potential health impact at the population level. And clearly, tier 3 is not where the action is, although there may be a lot of interest among the general public, let's say in direct-to-consumer tests and recreational genomics and nutrigenomics and other areas, but either the evidence is not there for their utility or it's being recommended against by different groups. So we're not you know, subscribing to one way or another. There's a lot of research that's ongoing that may reverse or might change some of these classifications. By the way, these are not set in stones, and as more evidence gets collected, classifications will be flipped based on the degree, the level of evidence, and whether or not evidence-based groups have weigh in on that.
Great, thank you. One more question. Can you discuss future plans for resources and databases to support state public health genomics activities?
Yeah, that's a big question here, and I'm looking at Ridgely. I mean, this is Moeen. I think our job is to try to get as good a job as to evaluate and get a comprehensive look at what's going on in terms of implementation action. This is work in progress. We're going to keep refining these tools. We're going to try to collaborate more with CDC programs and state public health to get at some of the data sources that would allow description of population health impact in terms of real time. And we welcome any opportunities to work with any states if people are interested. And Ridgely, you wanted to say something? Yeah, Ridgely is telling me that there is an ongoing right now as we speak an action collaborative that we launched last year with the IOM, now the National Academy of Science, Engineering, and Medicine, along with, it has a collaborative efforts of many people, many groups, including both public health and healthcare providers, to have a more comprehensive look at state readiness of implementation, some of the critical success factors like resources and other things, and champions, and keeping an eye towards the future, because things are changing very quickly in the field. I mean, the Precision Medicine Initiative will get us new data on an ongoing basis. So we are eager to reflect and collate all the resources that are available. And working with the implementation science community, I think there is a real opportunity to apply some real scientific backbone to evaluating these tools at multiple levels, both at the population level and the healthcare systems. So this is very much work in progress, and anyone interested in pursuing collaborations or be part of this action collaborative, feel free to email us, and we'll get you in touch with the right people.
Great. And another question that seems linked to this one, is there going to be any future impetus for increased funding for public health genomics in more states?
The one thing about the future is unpredictable, and we have been pushing for this agenda for a while now. I think the intent is there, the resources are not. But as the science matures and the need and the gaps for what needs to be done at the population level are revealed in terms of data that shows either disparities in implementation or disparities in outcomes or unavailability of certain resources, I think the proof will be in the idea that data will drive action. And of course, there is a lot of changes going on in the federal government as we speak, and we will be looking forward to working with the states in the next few years to maximize the benefits of genomics.
Great. Another question, what resources are available for rural outreach to providers?
I think the rural-urban question is very much on our mind right now. There is interest in analyzing and looking at disparities in implementation. I don't have the latest data in hand. I don't know if Ridgely or others have particular data points that they can share with the group, but there is definitely disparate needs and access in different locations, even within the same state. So I think by doing this first attempt, which is what we did, is by putting the resources together, we hope to work with state health departments and other localities to try to disseminate this information on a wider basis so that the benefits of genomics and precision medicine will reach everyone.
And I just wanted to add that I think some states have been using telemedicine and similar approaches, so starting to use the technology to reach places where genetics services aren't readily available. And as part of the Action Collaborative, we will be interviewing states and asking about that in particular. And if you hear from us about the Action Collaborative, we hope that you'll possibly be able to take the time and do that interview with us. It's hopefully going to give us a lot of really helpful information. And if you have activities in your state related to telemedicine, we'd be happy to hear about them, especially if there are links that we could include in our implementation and state clickable map.
Great, thank you. Someone asked, the term bidirectional has been used multiple times in the presentation. Can you clarify what you mean by that term?
Sure, sorry, and I probably should have taken a little more time to introduce that at the beginning. So the idea of bidirectional registry reporting is that states work with their cancer registry and they take the information that's provided in the cancer registry and apply the current guidelines to it to identify individuals that are at increased risk for certain conditions. So for example, with colorectal cancer, you would look at, going by the EGAP recommendations, you would look at everyone who has been diagnosed with colorectal cancer. not part of the EGAP recommendations, but also picking up women that have had endometrial or uterine cancer prior to at age 50 or younger. For hereditary breast and ovarian cancer, there's more categories. So you go through, you use the guidelines, you pick up those individuals, and then you, in some states, they can actually report the specific individuals. In other states, that what they report back to the institutions is the number of individuals that fall into each of those categories. And the idea is that it's an educational tool to let the institutions know about individuals in their states. It also perhaps can be helpful in terms of sort of quality control in those institutions. They can see, okay, well, approximately this number of individuals should have been evaluated for whether they should have had a referral for genetic counseling. How are we doing with that? So it's been used for a variety of purposes.
Yeah, so most cancer registries, so the idea of bidirectional is that it's not going, all the information is not going centrally to the state, but the state gets information digested and reflected back to the reporting organization in a bidirectional way to try to increase the adoption of evidence-based genetic guidelines like Lynch syndrome.
And if you'd like to know more about it, that video that we have in the toolkit with Greg Firo really does, I hope, explain the process fairly simply. So I think the idea of that video is really to explain what can be a fairly complicated process.
Great. And I did have one more comment, not a question, from Bev Burke, who shares, as a frequent user of all of the resources featured today, and later a contributor, I want to attest how useful they are in implementing public health genomics in our state, and to urge those on the webinar who have not yet examined them to do so with a mindset of how they could be utilized in their state or location. They are very helpful and have been instrumental in our public health genomics development in Connecticut. Thank you for that comment, Bev.
And second that, James, thank you, Bev, if you're listening. And Connecticut has been lucky to have you for all these years.
So that is all for the submitted questions today. Do you have any final thoughts for our attendees?
No, I want to thank everyone for taking time from their busy schedule, and we hope this was useful. I want to thank our 3 speakers from our office, and do get in touch with us. We hope this is not a one-time effort, but more of a dialogue with our office, and we thank Genetic Alliance and the APHA Genomics Forum.
And when we send you that survey, I know everybody gets surveys, and I know I don't always do a good job of filling them out, but we really, I promise, will be looking at them very carefully. So if you can take the time to fill it out, we would really appreciate it. We will definitely be looking at it and using the data from those surveys to try to improve these resources. And it's another chance to let us know about what we can do to better serve you.
Great. Thank you so much for joining us, and thank you to all of our attendees. We'll have the recording and the slides up shortly. And of course, as always, please join us for future webinars. Thank you.
Thank you.